case is a 44 years old female. She was diagnosed BALL in 2018, and at that time she was 36 years old. And for the cytogenetics and for the MLPAs, like okay, this one. Oh. Pointer ก่อนนี้ pointer ตรงไหน MLPA is like a multiplex ligation dependent okay okay amplifications also negative, and also the multiplex rearrangement, cytogenetic rearrangement that in our center done just only for probes like ETV6, lung 1, something like that. So the result is negative. So the patient know the high risk of ALL. So the doctor treat the patients with like a pediatric protocol, pediatric inspired ALL protocol that in Thailand we call the TPOC protocol regimen. And so the patient complete the treatment in 2020, and the monitoring of the flow cytometry show that MRD is negativity. And the patient no mass sibling or MET-related donor. So, and five 5 years later, the patient have the relapse again, relapse BALL, and so the doctor treat the patient with also the TPOC protocol, and for cytometry again MRD negativity. But at that time, I'm not sure the doctor not offer the patient for the transplantation, maybe because the patient have no massive ring or MET-related donor. So, okay, the doctor still treat the patient with the ALL protocol. And unfortunately, one year after that, the patient developed relapse ALL again. Okay, after the phase 5 of the ALL, that at that time is the drug is like a shop-like regimen, and the chromosome is like a complex chromosomes, and so the doctor offered the patient treat with the FRAC regimens, and again the patient have the refractory disease and refer to the Ramathibodi Hospital. And so on December 2024, okay, I gave the patient with inotuzumab, okay, it's the monoclonal anti-CD22 antibody. That I discussed with the patient that okay, she received the monoclonal antibody, and then if she achieved the complete remission, okay, go on to do like a haploidentical stem cell transplantation, and she got luckily that she got the complete remission and MRD also negative. So I proceed to do the haploidentical, and donor stem cell is her mother. Yes. Oh no, not her mother. I'm saying that it's her younger sister. Her younger sister. And so the patient after transplantation, just only 5 months, patient have the relapse again. So right now, what the treatment regimen? I talk to the patient that okay, sometimes okay palliative treatment, but she and also her family also okay fighting for cure the cancer. So okay, I use this panel to treat the patient. So that. When we look at the single agent, we will see that the best efficacy of the drug is the L-asparaginase. So I think that, okay, I don't like doublet, I like the triplet, because, in the hematologic malignancy, usually we use the multi-agent to treatment of the patient, especially in the leukemia. So the second rank is the fludarabine, and the third rank is the idarubicin, that's right. So when we look at the doublet, okay, combination to drug, okay, we will see that L-asparaginase plus the fludarabine is okay, and the another is L-asparaginase plus venetoclax, and the third rank is L-asparaginase plus the idarubicin. And so that I told you that, okay, I prefer 3 agents. So I look at the 3 agents that, okay, our asparaginase-based regimen plus with the fludarabine and also venetoclax, and our asparaginase plus the fludarabine idarubicin, and our asparaginase fludarabine doxo. So I would like to ask you that, which one do you want to choose for this patient? For the 3 DAC, I think 2 DAC is not enough. เอาไหมน้องไอเอาไหม เหลือน้องๆที่ลาวไหม
It's not about this, but she ever respond inotuzumab before.
I forgot. Sorry.
Yes.
Okay, no. She respond inotuzumab, get the complete remission, and proceed to do haploidentical, and I give her the inotuzumab maintenance. But she still progress on inotuzumab maintenance therapy. So I forgot that right.
Okay.
So, but in the panel we don't have the monoclonal anti-antibody. That's I'm looking for that. But this is a part that no way, just only chemotherapy. And for this panel, I forgot to tell that 12 drugs is like a personalized, not the commercial. That's right, not the commercial panel. No, she respond to the ALL protocol that and 2 times and not respond to FRAC regimen, fludarabine, high dose Ala-C, some high dose cytarabine. Not respond. 2 cycles, no response. So relapse again. But she ever respond to the AL protocol like a short regimen, high dose methotrexate, Ala-C that have the many drugs combined. That's asparaginase. Okay, so yeah, it's in the AL protocol. You're right. So
Yes, I think maybe because respond some TPOC protocol before, so that's why she respond LS. For me, I will choose venetoclax combination because the response is look good, and because she never exposed venetoclax before.
No, because for this case, if we look at the data, the patient not respond FRAC regimen. That's right. That contain of the like a fludarabine, and but when do the transplantation, I use the haploidentical. That's right. So it's the fludarabine, melphalan, some PTCY. So it's like you used to respond a little bit for the fludarabine. But our asparaginase and also venetoclax. Okay, so I think that everyone maybe also me that I shoot the first one, but I'm also like Dr. Vishian that.
I still wonder why don't you send the test with for example B cell inhibitors such as BTK inhibitors or the drug such as dasatinib, because there is a base that dasatinib can use in the ALL.
Yeah, right, but I don't. At the first use, I don't use the dasatinib because in ALL usually they have the mutation, something like that. So I'm not sure to that. So for the like a TKI mutation, so I think that we prefer like the first rank is like our asparaginase combined with the venetoclax and also the fludarabine. That's right. But I told you like a venetoclax is more like a bone marrow suppression. So for this case, I shoot for the 3 DAC. We have this one, this. So I shoot this one. I shoot we call the FRAC IDA. So I shoot because I think that's venetoclax we need to take every day and more bone marrow suppression. So usually maybe we lost the patient. So I choose the fludarabine, idarubicin, asparaginase. My God. That's right. You're right. So you're right. The patient, but like luckily that patient achieved the complete remission again, right? And achieve the full donor communism because at the time that we relapse, the donor cells decreased to 50%, but okay, it returned to 100%. And okay, but unfortunately that you already know that, okay, for second cycle, she developed the sepsis. And I talked with discussed with the family that, okay, I think that is the time to stop because we try a lot. I forgot to tell that the first time I also asked them that, okay, to do the CD19 CAR T cells, but she then cannot afford for this, for the cost of the treatment. So okay, for this case. So for me, I think that's okay. The drug I also use I also use this drug for 2 patients. That's before these patients. The first one that I use is the T lymphobatic lymphoma, TLBL. That's a very relapse refractory, also refractory to the ALL protocol, hypercivat, nelarabine combination regimen, and you understand. So, okay, I used for the bortezomib something to look at that, but it's not respond. For the data for the drug, it's like a red, always red. So even you 3 dark, 4 dark is a red. So okay, no treatment of choice. But yeah, right. And also the second one is like a Burkitt lymphoma. Yeah, right. So everything red. So no choice. Also, even the venetoclax is also no response. So for these 2 cases, just only this case that get the good results. So I think that's the test that I use. I also agree with you that the panel that you use and the test is like okay. My case is the resistant. That's right. So the drug is also resistant. So I think that is the accuracy of the test. I think that's greater than 90%. So I think that is okay. But it's just only used to combine the combination of the therapy. So for me, I think that is maybe like a good best benefit in the case that we use for the reinduction, something like that, and then proceed to do the transplantation or to do the CD19 CAR, because I think that's it. If we use is maybe not preferred for the maintenance therapy, that we already know that the cancer, the cancer cells or blood cell or tumor cell, usually they very behave aggressive. So usually they develop the resistance. So I think that's only short time to do this and then proceed to do the another. And if I can went back to, and the other is like, okay, the cost is very expensive, something like that. And so it's like you said that, okay, the test is in the vitro, not in vivo. So in vivo maybe have the other confounding factor, other factor that affect the drug that maybe like have the good response as in the vitro study, something like that. So if I can go back to for this case, I think that's maybe use the test here, maybe here, or maybe here. Because if we can use the, shoot the drug that best for the patient, we can go to the, next for the transplant or something, and also the maintenance therapy. But for this patient, she failed a lot of the chemotherapy, 3 lines, 4 lines. So I think that when we use at the last, maybe cannot save her life. So.